Good afternoon to you all. I've been given the very difficult task to follow Kyle and Mike in a talk, and I will still try to do that. So I'm going to take you back to humans and talk about slim and ultra-slim scope for peripheral nodal diagnosis. This is my conflict of interest. So what we had till now was the 6 millimeter and the 5 millimeter scope. The 6 millimeter scope can go maybe to the lower bronchi and maybe take a peep into the segmental bronchi. The 5 millimeter scope can go into the segmental bronchi and maybe take a peep into the subsegmental bronchi. But now we have the new slim and ultra slim scopes. Fuji is the new kid in the block. The slim scope, the 4 millimeter scope, can go well beyond the subsegmental bronchi to even 4, 6 generation bronchi, and the MP190, the 3 millimeter scope, can go practically, in some cases, all the way to the pleural, so you have to be careful. It can go anywhere. We had the XP190 2.8 millimeter scope for a while, but this scope has a 1.2 millimeter working channel, and this is not suitable for EBUS. That for me is a must, and you cannot use a variety of sampling tools with that. So if you're going to compare the slim scopes to the robots out there, so the slim scope, the P190, is pretty much similar to the Monarch robotic scope in terms of outer diameter. It even has a similar working channel. They both has constant vision, and the Olympus MP is a little slimmer than the Ion. It's 3.5 versus 3. The working channel is a little bit narrower, but the Olympus MP has a constant vision, and the Ion, it's alternating. You have to take the camera out if you want to put in a rebus or some kind of sampling tools. But still, we have enough tools to sample, because you know the tissue is the issue. We can use the needles that you all use with the ultraslim and the slim scope. There is a dedicated biopsy forceps for the MP, and of course with the 4 millimeter scope you can use a bigger forceps. And of course there are the two new Airbac cryoprobe. The 1.1 you can use with both scopes, and the 1.7 with the slim scope. Now I tried here to compare the different platforms in terms of things that I think, parameters that I think that is important for peripheral navigation. Well, first of all, is price. No doubt that slim scopes has a low price compared to the other platforms. And disposables, with slim scopes, you can use only your sampling tools. With the other platforms, for each bronchoscopy, you pay a lot of money. Tip flexion, this is very important to prevent tool-induced flexion and to make your final approach to the nodule very accurate. So you have it with the slim scope, you have it with the Monarch, you have it with the Ion, but when you use the catheter, when you use a preflexed catheter, it's more difficult to do that. Navigation, with slim scope you have no navigation. For me, this is part of the fun. You have navigation with all the other platforms. Peripheral vision, very important. I will touch that a little bit later. You have it with the slim scope, you have it with the bronchoscopes, with the robotic scopes. The Ion, of course, is alternating. You have no peripheral vision with the electromagnetic navigation platforms. If you are using EMN-driven platform, it can interfere, and advanced imaging, which we already heard is very important, then it can interfere with the navigation if you use the Monarch or the electromagnetic navigation. I will not get into bleeding control and haptics. For me, it's very important to hold a real bronchoscope in your hand and actually feel what you are doing and try to, if you have bleeding, you can immediately negotiate that. Stability, the robots are very good at that. The EMN, once you are there with your radioscope, once you put in a stiffer tool, they may be a tool-induced catheter deflection and you will be out of your target. In the slim scope, it's operator dependent. It's really dependent on you, how stable your end is, and you can, as we said, you can control the tip of your scope. So, Mashidi Aoki has published a lot on SIM scopes and ultra-SIM scopes, and in this paper he actually used virtual bronchoscopy to navigate with both scopes and compare between the two of them in yield of, in terms of yield and reach. And you can see that in yield, he had an overall 74% yield with 65% below 20 millimeter nodules. But if you just look at malignant tumor, you can see that he has a 81 total yield, but 76% below 20 millimeters. Now, if you compare the reach of the two scopes, he found the ultra-thin bronchoscope could reach more distal bronchi than the thin bronchoscope. It was median 5th versus 4th generation bronchi. Now, in my experience, and this is one of our cases, you see this small nodule right in the right upper lobe. Usually the difference between the scope is more than one airway degeneration. It can get to 2 to 3 airway generation further. And I think it's not because Aoki is not a good bronchoscopist, but I think that this is because he used the conscious sedation, and I'm using a general anesthesia plus navigation ventilation protocol, which opens the airway. And I think it doesn't matter which platform you use, you have to use general anesthesia with a dedicated ventilation protocol. Another thing that I found out, that if you go out with the 4 millimeter scope and you stop, you cannot go any further, and you switch your scopes to a 3 millimeter scope, so you can get to your target, you work there for a bit, and then when you change the scope again, when you wedge the 3 millimeter scope into an airway, you can actually stretch the airway, and in that way you can go again with the 4 millimeter scope and get much further than you initially succeeded. In the rich study, they actually compared the Monarch and the Slim scope, which are pretty comparable in the outer diameter, in how far they can reach in ventilated cadabras. And what they found is that there is a considerable difference between the two. For example, in upper lobe, in RB1, it's 8 versus 3.5 bronch generation, and for LB1 per 2, it was 8 versus 4.5. But how did they do this study? They actually put the scope in the orifice on the inlet of the segment. They pushed in a wire as far as they can go, and then they were just pushing the scope, and the bronchoscopist was not directly involved in selecting a pathway. And those two authors, Alexander Chan and Colin Gillespie, they testify upon themselves in the article that their non-robotic experience in navigating to the periphery is actually electromagnetic navigation. And for me, this translates to using a 6 millimeter scope with no vision at all at the periphery. So this is taken for the article we just was talking about, from the REACH article. And you can see here the difference between the reach of the Monarch scope, okay, and the thin scope. Okay, you can see the kink here. This happens because you simply push the scope into a wall. The image below here are taken from our procedures, and you see that, first of all, if you do this loop, you do not get this kink because you are actually moving the scope where you can see. And those images looks more similar to the robotic one than to those. And you can even drive your scope in 3 dimensions. So I ask you, would you drive your car with your eyes closed? For example, you can see this lesion here, and this is the bronchoscopy here. Okay, you can see how far. This is very similar to what Michael Pritchett has shown us. Okay, this is the right main. Again, right main, bronchus intermedius, RB6, posterior segment, and you can see how far it can go until a moment you can actually see the lesion and the emphysema lung around it, okay? You can see it again. Very similar to robotic view. This is the lesion, this is the emphysematous lung, and this is this nodule, okay? And it can go even further. So, you heard it before, it doesn't matter what platform you use, you have to have an integrating advanced intraprocedural imaging. And for me, the necessary products are augmented fluoroscopy, okay, which is actually creating a virtual, it is important for you to understand it is a virtual image of the nodule on your fluoroscopy screen. You can get it by using a cone beam CT or lung vision, and it's actually making the invisible nodule visible again. It will help you with the final approach, but it will not compensate for CT-to-body divergence. For that, you need to have some real-world information. One of these, you can achieve it by using an rebus, but as you heard, atelectasis and bleeding can create artifacts. But the real-world gold standard imaging is tool-in lesion. You can see this small nodule here. I navigated with I think it was a 4 millimeter scope, got a rebus image, but you can see the difference between the real world and the lung vision augmented fluoroscopy, okay? And if it was a video, you can see it moving along like a pendulum, okay, into this virtual image and out of these virtual images. So you can actually use thin scopes with cone beam CT, as with any other platform. You can see here this little Chereus-like GGO in the periphery. You can see here the augmented fluoroscopy. You can see here tool-in lesion. And this is actually how it looks. You can see another very peripheral in the costocardiac angle here. We were able to drive all the way to it with a 3 millimeter scope, but then I could see that I can reach the same place with a bigger biopsy tool by using a 4 millimeter scope. And of course, you want to see that you are not superimposed, so you are moving the C-arm with your tool or your rebus inside the nodule, and you can see that it's exactly here. And of course, this is for me, if I get a radial EBUS image, this is enough. I don't have to do tool-in lesion spin. So this is the biopsy here. So if I get this radial image and the augmented fluoroscopy, I don't have to do a tool-in lesion, but here I did it. You can see this is the endotracheal tube. This is the 4 millimeter scope. You can just follow it. All the way here. But you don't have to have a fancy cone beam CT system. You can do it with lung vision. Carl talked enough about it, but you have the product that I look at, the same product, is actually having a augmented fluoroscopy, tool-in lesion, and this 3D imaging, and it goes like that. Here you have a very tight para-aortic nodule. In this case, you definitely you want to know that you are in the nodule and not hitting the aorta. And this is your augmented fluoroscopy. Here is the aortic arch. This is the nodule. This was an adenocarcinoma eventually. And this is your tool and lesion image. Okay, this is the aorta, this is the nodule, and this is tool and lesion image. Okay, so how do I get there? Because with slim scopes you have no navigation. So one of the ways to do it is, if you want, is to use a slim scope with virtual bronchoscopy. You have different systems which can do that. You can use the Archimedes or the lung point version of it and simply follow the lines with your slim scope. Or you can use lung vision. Here you also have a fly-through, a virtual fly-through, but here you also have the airways projected on your fluoroscopy, so you can use that. Another way is to use the Kuromoto airway tracing. This is a very nice way to start and look at the CT and learn how to navigate yourself. Actually, Kuromoto and Morita wrote a whole book about that. And what you do is actually looking at the CT, identify the different junctions that you have to go, and creating some kind of schematic drawing and to pinpoint where you want to go. Now, how I do it? I'm not really using the force, but you can train yourself those, and by looking at the higher resolution CT and looking at the airways going into the lesion, airways around the lesion, and create in your mind a three-dimensional map of how to get there. It's not easy at start, but as you put in it some effort, train, you have volume of cases, you have patient, you will get there. So tipping tricks for peripheral reach, first of all, use general anesthesia with navigation ventilation protocols. This is the one I use. It's the same principles, but I know there are various, great variety in that. Start navigation as soon as possible before atelectasis set in. Do some lung recruitment maneuvers, ventilate to tidal volume from time to TLC from time to time. And as regarding thin scopes, I use both 4 and 3 millimeter scopes. They are complementary. Now, when you have vision in the periphery, you can actually see the airway collapsing on you. And for that, you can gently use the syringe to inject some air, or sometimes if you wedge your scope, the air that is been pushed out from your working channel, when you put in a tool, will open this airway and you will see the next generation of airway. Scope stiffness can be controlled with different tools in the working channel. Okay, so the importance of peripheral vision. You can see here this small, like 8 millimeter nodule. You can see that lung vision was able to create a nice, we were able to identify it with lung vision, and this is the augmented fluoroscopy. And driving up there with a 3 millimeter scope, you can actually see this carcinoid inside the airway, and we actually took most of it out with a 1.1 millimeter catheter. In this example, this is a 5 millimeter nodule in the left upper lobe, and there is maybe one airway around it, but when you drive up there with a 3 millimeter scope, you can see that you have 1, 2, 3, 4, 5 different airways that you couldn't see using the CT. And when you start to push your riboscope to each of those airways, just in this one, you see a little bit bleeding because I've already been there. You see this image, and this was a squamous cell carcinoma. Again, the importance of peripheral vision. This lady had a PET-avid nodule that was trying to be biopsied by transthoracic CT with her large pneumothorax, and then she was referred to me. I had to persuade her to do the procedure. And when you drive up there, this is a lung vision augmented fluoroscopy. This is a 4mm scope right inside the lesion. What we saw there was a large broncho cell. And once we sucked out all what was there, and this, of course, rebus image disappeared. And in a follow-up CT after 3 weeks, you can no longer see this. Okay, so this is the difference between actually see what you're doing and just sampling something you're not seeing. Another example of that, a rather large nodule, PET positive. When you go up there with a scope, you can see that there is actually a 3-4 millimeter carcinoid blocking the airway, and all of this is actually post-obstructive pneumonia. This is the same thing with leiomyoma. Okay, so if you have peripheral vision, you see exactly what is out there. So, can we have enough tissue with slim scopes? In this example, this young lady, which had a lingular, it's about, I think, 9mm nodule, she was all for VAT. And then she came to me, we were driving up there, we saw the lesion endobronchially, and here you can see the 1.1 cryoprobe. You can see the amount of tissue we took out of there. That this turned out to be hamartoma. And from some reason, someone decided to do a follow-up CT, and you can see that this whole nodule just radiographically disappeared. Okay, so you can take a lot of tissue. So, in conclusion, slim and ultra-slim scope is a good option for peripheral pulmonary lesion sampling. It is excellent peripheral reach, continuous vision, tip flexion, and tool flexion correction. You have a good selection of sampling tool, immediate bleeding management, relatively cheap, can be used with various navigation system, works great with advanced real-time imaging, but it's not a plug and play. You need proper technique and training, and you have to be persistent, and you have to have a volume of cases. So, thank you.